Hello, I'm Wayne Sullender from Center for Global Health, and I welcome everyone to this select but very interested group that's here today. I'm pleased to introduce Dr. Miravalle, who will be our presenter. He's from the Department of Neurology, where he serves as Vice Chair for Education, also Director of the Neurology Residency Program. In addition to his interest in medical education, he has a focus on neuroimmunological disorders, and he'll be speaking with us about the epidemiology of these diseases today. So, welcome.
Thank you, and it's a pleasure being here, and thank you for coming. Is the microphone, can you hear me there? Okay. So we have a nice mix of people in the audience. So I will probably concentrate more on MS, but I will touch on other neuroimmunological disorders to try to explain what do we understand in terms of the epidemiology of these disorders. There is a very interesting overlap between infectious disorders and neuroimmunological disorders, and I will try to cover those. So let's talk about the disease first. Multiple sclerosis is a very common disease, and the incidence, both incidence and prevalence, continue to increase. Currently, there are over 500,000 Americans that have been diagnosed with multiple sclerosis, and of those, 2.3 million in the world. Of the Americans, there are clear pockets that are related to geography, and definitely Colorado is one of those areas that has a high prevalence and incidence of MS. 80% of those patients will have the first symptoms between the age of 16 and 45 years old. And the female to male risk ratio continues to grow. When the disease was first described in the 1980s, was thought to be a predominantly male disease, and in the actually 1920s, in one of the early papers, they described that MS is a male predominant disorder. And now we know that that's the exact opposite, and that ratio continued to increase, likely due to many risk factors that has been increasingly prevalent in female population, probably as cigarette smoking and particularly obesity and different type of role that women have in society are exposing women to other risk factors that are changing the risk, but also as women have access to healthcare, the diagnosis itself becomes more readily available. What happened with an MS patient if we don't intervene clinically? Well, the outcomes are unfortunately very poor. 50% of patients will require the use of ambulation, a cane or wheelchair devices at 10 to 20 years from diagnosis. 30% of patients will become wheelchair bound if we don't intervene. And without interventions, the old data from the 70s and 80s suggested that lifespan will decrease by 5 to 10 years on average. Now with interventions, we find that patients live longer. And that also could be one of the factors why the prevalence of MS continued to grow, because not only there are new cases impacting the incidence, but actually patients live longer, affecting the prevalence. This is a very costly disease. It's approximately thought to be $35,000 per patient per year, though we know that most of our disease-modifying therapies for MS are around the range of $60,000 per year. That's the total cost, and of course, because MS is the leading cause of disability among women and the second cause of disability among men, and affect people in the most productive time of their life, the indirect cost of the disease is actually much larger, as these patients will have to get disability and will not work. What causes MS? Well, that's a multi-million-dollar question. We don't know the answer. We know, however, that most likely is more than one thing that is involved in the pathology of the disease. And traditionally, we think about infectious agents, a genetic component, as well as environmental factors. What is the estimated risk of MS in a given population? Non-Hispanic white individuals have an estimated lifetime risk of MS, which is thought to be 1 in 400, and this is not considering geography or latitude. This is overall risk in the world. The risk, of course, in higher latitudes in the world is thought to be higher, and I will cover that in future slides. It has been proposed that there is a lower risk in Hispanic, Black, and Asian populations. However, this estimate might be contaminated by the fact that in these populations, access to healthcare and diagnosis might be lower. And as these patients have better access to MRIs and healthcare, the risk in those populations might be equal as the risk in white non-Hispanic individuals. We know that in cases of monozygotic twins, the risk of MS is a fivefold higher. So there is a genetic component, and having a sibling with multiple sclerosis will increase the risk of MS from 20 to 40-fold. Let's talk about viruses. Since Charcot described this disease in the 80s, it's thought to be a viral disorder. There is a virus that causes disease. Well, we know that probably viruses are involved in the pathogenesis of the disease, but it's not the cause. The classic description is with the mononucleosis or Epstein-Barr. And there is an interesting relationship between mononucleosis in the world and income in societies. So places with lower income tends to have a higher rate of infections of Epstein-Barr that occurs early on in life. And most kids will be asymptomatic. Whereas places with higher income in the world tend to have more protective environments with better sanitation, and they delay the onset of exposure to these viruses to the immune system. That's why when you look at Northern Europe and the US, the rate of first infection of Epstein-Barr that usually brings symptoms is higher among adults. That has been thought to be one reason why, if your immune system has been naive for certain viruses and all of a sudden you're exposed to viruses like Epstein-Barr, your immune system might mount an immune response that is more prompt to create autoimmunity. And I will cover this a little bit more in detail when we talk about the hygiene hypothesis. But basically, the thought with the relationship of Epstein-Barr virus and MS is that the virus may have some similarities in the antigens present in the virus that cross-react to proteins in the myelin or the central nervous system, a process called molecular mimicry. So once the immune system recognizes a virus, you will mount immune responses primarily driven by T memory and B memory cells that then are ready to react to something that looks similar to that. And if those responses cross-react to myelin antigens or to CNS antigens, those patients might have higher risk of developing brain or spinal cord autoimmune disorders. So the younger the immune system is, or the younger the individual is, when exposed to these antigens, the lower the chances of that immune reaction to lead to autoimmune or dysfunctional responses. So it seems like patients who are exposed to these type of viruses later in life have a higher chance of developing autoimmunity. And please interrupt me if you want me to expand or you have any questions. We have Tim Ballmer in the audience. He is a world expert in multiple sclerosis. I'm sure, Tim, you will have very good comments about this. But the larger study that looked at the relationship between Epstein-Barr and MS was done in the military personnel, and they look at literally over 50 million serum samples for over 50 years that they had. And they tried to identify the relationship between seroconversion to Epstein-Barr and risk of MS. Not surprisingly, they found that 95% of the people studied were positive for Epstein-Barr. So we know that this is a very common infection, and most of the time asymptomatic. Of those that were seronegative, they followed them over time with serial blood samples over 1 or 2 years to identify when is these people going to seroconvert to Epstein-Barr positive results. And once they did, they tried to identify what is happening with their risk of MS. Not surprisingly, these 10 individuals that you can see listed in this slide, you can see when is the time that they became positive for Epstein-Barr or infectious mononucleosis, and when MS was diagnosed. And you can see a clear temporal relationship between the positive seroconversion to Epstein-Barr and the onset of multiple sclerosis that in some cases was just a few months apart. This doesn't mean that MS is caused by Epstein-Barr. This means that there might be an association between acquiring the disease later on in life and mounting an immune response that is abnormal. We know that, again, 95% of the population is positive for Epstein-Barr and they do not have MS. So they still have to have something that triggers the immune system, and in this case it's Epstein-Barr, but you have to have other factors in your immune responses that will prompt that immune response to become autoreactive to your brain.
May I ask a
question about
Sure.
this? So these were 10 individuals who were seronegative when they started their investigation.
Exactly.
And then they were able to show they seroconverted, became later developed MS.
Exactly.
Did they have the converse? Did they have people that developed MS that did not?
Not in this study, but in clinical practice, absolutely. We know that there are patients with MS that they were never exposed to Epstein-Barr. And so, again, it's not a cost effect. It's probably something that is one of those factors that you need to have once you have an immune system that is more prone to cause autoimmunity. Something has to trigger that. And clearly Epstein-Barr is one of those factors, but absolutely not the only one. So it seems like age of onset of MS also is distributed very unequally in the world. And you see that in lower income places, the age of onset tends to be younger. And again, the age of onset for certain infections or exposure to certain infections tends to be younger in those places due to poor sanitation, poor vaccination campaigns. So if there is an infectious agent as one of the components for the development of the disease, it is possible that sanitation and vaccination has to do with earlier exposure. When I talk in future slides about the hygiene hypothesis, you will see an opposite relationship between poor sanitation and the risk of MS. So we don't completely understand this relationship, but it's possible if, for example, infections like Epstein-Barr play a role. Having early exposure to the virus might have a protective effect towards autoimmunity, but in those individuals who Epstein-Barr virus prompted the disease from happening, depending on what age you are exposed to the virus, your disease might manifest earlier or later. What is the mechanism in which a virus can cause autoimmunity? Well, here you will see a few circles with red nuclei and blue nuclei. T cells and B cells are both involved in autoimmunity. The red nuclear cells are representing those cells that are more prompt to react to self-antigens or to react to self-antigens. So as I mentioned briefly before, if a virus or any infectious agents share some similarities with own antigens present in your body, in this case in the myelin, after the first infection, you could develop memory cells in both T and B cells that then are going to try to look and search for similar antigens and respond to those. That's a process called molecular mimicry. There are other processes, including bystander activation, in which if you're exposed to a virus, you have an immune response, and there is a release of cytokines that subsequently is going to activate other immune cells, that those cells, if they were autoreactive, is going to cause secondary autoimmune disorders. So both processes might be present in the way these viruses or these infections might trigger autoimmunity. But as you can imagine, and you see here, you need to start with an immune system that is already dysfunctional, an immune system that has autoreactive cells or did not go through a process of self-tolerance and try to literally destroy the cells that are autoreactive. So the story about genes and MS is very similar to what I told, because even though there are many genes that has been identified with the susceptibility of MS, most of those genes had to do with proteins that are going to modulate immune responses. So there are over 110 genes that has been identified that will change the susceptibility of multiple sclerosis. The strongest association of those genes has to do with the HLA-DRB1 system. It's present in 30% in people in high risk. There are clear clusters of MS patients that they do not follow the typical latitude gradient that I will explain in a minute. The classic example is in Sardinia, in the middle of the Mediterranean. We know that there's a low incidence of MS from geography. However, in that island, there's a high prevalence of MS, and that's likely driven by this presence of this type of genes. I briefly mentioned that in monozygotic twins, there is an increased incidence of or risk of developing MS. We usually tell patients that if you have MS, your offsprings, your kids, might have a higher risk of MS, and that's usually thought to be around 3% chance in Colorado, whereas the risk of MS in Colorado is thought to be 0.7% risk. So just because it's a high incidence area. There are rare variants, though, that certain genes like the CYP27B1 gene that is not related to immune modulation, but this gene is related to metabolism of vitamin D. And I will put that on hold for now because I will talk about vitamin D later. But that's one of the factors that has been shown to increase or modulate the risk of developing multiple sclerosis. So what about race and MS? Well, it's been thought that certain races have a different risk of developing the disease. In terms of the lowest risk, Asian, African, Amerindian, and mestizos are thought to have the lowest risk of MS. I mentioned briefly that probably that's contaminated by the fact that certain races have lower access to healthcare and diagnosis. However, it's interesting that the phenotype of certain races is different. The classic example is Asians or Japanese, in particular that they tend to have a higher incidence of opticospinal MS. What that means is that the disease will present clinically differently, affecting the optic nerves and the spinal cord, whereas that's not as commonly seen in Caucasians and Europeans and North Americans. When you look at how these migration patterns occur in history, one of the first theories of the first population in America and the continent was through migration through Asian populations in the Bering Strait 15 million years ago. So there is a clear link between certain Mongolian features in Native American individuals. And when you look at the prevalence of opticospinal presentations in North and South America, those individuals have a higher rate of opticospinal presentation. So probably related to the risk inherited by this Asian migration in history. Conversely, people that is white, Caucasians, and Northern Europeans have a higher risk of MS. I briefly mentioned about the hygiene hypothesis, which try to explain that if you're exposed, if your immune system is exposed early on to certain antigens, particularly driven by infections, you might have a better way to suppress dysfunctional autoimmune responses. It has been seen that in places with poor sanitation, poor vaccination campaigns, and higher incidence of infantile infections, the rate of autoimmune disorders, including asthma and multiple sclerosis, is lower. So this theory prompted the development of, well, what happens if we induce infections? Can we modulate the risk of MS? And there is currently 2 clinical trials that are in phase 2 looking at inducing helminthic and parasitic infections in MS patients. And so far, from a safety standpoint, we have good data on those trials. And from an efficacy standpoint, there is some indication that MS patients who are exposed to certain parasitic infections may have a better outcome in terms of relapses and MRI lesions. The first description of that was in South America, and the observation was that MS patients who have concomitant parasitic infections, with particularly Chagas disease, but other infection has been described, they have a better outcome and an immune response that tends to be more towards an anti-inflammatory driven by T helper 2 versus a pro-inflammatory immune response. So more to come here in this hygiene hypothesis in MS, but it's interesting to see the association of certain infections and the risk of developing MS, as well as once somebody has MS, if you have a concomitant infection, that might modulate the immune system and might result in better outcomes. We still tell our patients to use vaccinations and in their kids, so there is no reason to promote infections. But we may learn a lot about the disease by looking at these interactions. This is just for you to believe me that Asians went to America many, many years ago. This is just a cartoon. So talking about migration, traditionally we knew that the incidence of MS tends to be lower around the tropics. The lowest incidence is around the equator. And as latitude increases, the incidence of MS increase. There are many reasons to explain that. Probably geography, genes, and vitamin D and sun exposure has to play a very important role. But as the world continues to be a very dynamic environment where migration is now very common, we see that those numbers are changing. The global estimated prevalence of MS is 30 per 100,000. For example, the US has one of the highest ones that is thought to be 140 per 100,000, whereas, as you can see, when you go to the Americas and Western Pacific Islands, the incidence drops significantly. What happened when people move? And this is just a color chart to show you those incidence numbers. So what happened when people move in the world? Well, migration studies suggested that if you move from a low incidence area to a high incidence area before a certain age, and the cutoff for those studies was 15 years, you acquire the same risk of MS as if you were born in that high incidence area. Just to give an example, if you're born in Israel that has a low incidence area of MS or low risk of MS, and you move to the US, to Colorado, before the age of 15, your overall lifetime risk of MS is as high as if you were born in Colorado. And conversely, if you're born in a high-risk area and you move to a low-risk area before the age of 15, your overall lifetime risk is low. So that clearly tells us that there is something in the environment that modulates the risks, but there is also something genetic that predisposes that risk. And when you look at why people move, it's interesting that the main reason why we move depends on where we are coming from. So people coming from low-income places, they tend to move to higher-income places, driven by jobs, driven by financial and economical reasons. And that's why you see here that the U.S. immigrants are increasingly born in Latin American and Caribbean. When you look at why people from high-income places move, is usually looking for a better lifestyle, looking for better weather and very climatic conditions. And they tend to move later on in life after they accomplish certain financial stability. So U.S. immigrants increasingly are living south, living to South America and Central America, and usually that happens later. So when you put both things together, you realize that these migration patterns are going to change dramatically the incidence of multiple sclerosis, because you're bringing populations with low risk of MS to high risk areas early on in life, and you're bringing people with high risk of MS to low risk areas later on in life. So that's one of the reasons why this latitude gradient is changing, and probably has to do primarily with these migration patterns. So this is just a schematic representation from The Economist, looking at why people move, and this push-pull theory, what pushed people to leave their home countries and what pulled people to get attracted to certain areas. And definitely financial and economical factors are the main reason for low-income places. And as I mentioned before, climate, weather, and lifestyle is the main reason for high-income places. Those are just numbers showing you that the prevalence of MS continued to grow. In the top chart, A, B, and C shows 3 different areas with a relatively high prevalence of MS. And the incidence, the new cases per 100,000 in a given time, in this case in a year, also increased, particularly in the southern hemispheres. That could be a result of 2 things. One, migration, as I explained before. People with high risk are coming now to the south. And 2 is the availability of MRI and resources, that in this later study in 2013, as you can see, emerging countries have the highest increment in the availability of MRI and physicians, leading to more accurate and earlier diagnosis. So probably both factors affect why the incidence of MS is increasing in the southern hemispheres. This is just to show you what is the number of MRIs per population. Of course, blue and light blue is the highest number of MRI per population, and the red is one of the lowest. And you can see that in those areas that we thought there is a low incidence of MS, probably that's driven also by, do we have MRIs in order to diagnose the disease? And that might be one of the factors. So once you feel a little bit comfortable about a theory, there is some group that tries to make you feel that that's wrong. And this particular group in Australia actually is trying to argue that this gradient never existed. There is just a lack of diagnosis. There is some bias in terms of how the disease has been diagnosed in different places. And this increment in prevalence and incidence is too rapid to be considered to just a change in genes and a change in mixing populations. So the rapid increment probably has to do with something in the environment that is completely independent to migration, is completely independent to genes. We still don't know. Clearly, there is an increased incidence and prevalence. We still don't know whether that's just simply driven by migration, by better access to diagnostic tools, or it's just the disease is actually getting more frequently diagnosed. What is clear is that females are more frequently diagnosed with males, and that ratio continued to grow. From 1:1 that was thought to be in the mid-1950s, now the risk is thought to be 2.5 to 1. So for every man diagnosed with MS, 2.5 women will be diagnosed with MS. And that ratio is as high as 9 to 1 in places like Asia and Japan. We can argue that, well, women's now, as I mentioned before, they have better access to healthcare, but also it could be something, again, in the environment that is increasing that risk. There is a clear relationship in between estrogens and MS, and high levels of estrogens have been thought to be protective for the disease. So some groups are looking at, well, now that women are working and they are delaying pregnancies for an average of 5 to 10 years, is that change in the pregnancy rate in the first pregnancy had to do with the risk of developing MS earlier? And that's a theory that has been not proven yet, but it's pretty interesting, the relationship between, again, estrogens and multiple sclerosis. What about vitamin D? So we know that when you induce MS in animal models, in the experimental allergic encephalomyelitis, if you have animal models that are deficient in vitamin D, they have not only a higher rate of MS, but also once they develop this animal model of MS, they do worse. So those studies then were confirmed with large epidemiological studies in humans, and low vitamin D predisposed to both a higher risk of multiple sclerosis, and once you have MS, to worse outcome. So what is the relationship between vitamin D and MS? So when you compare with other studies, in these cases with colon cancer, in the estimated global vitamin D levels, you see that places with high incidence of MS are also places with lower vitamin D levels in the population, likely from dietary changes, but also exposure to sunlight. So what is the relationship between vitamin D and the immune system? Well, this is just a summary of the most important relationship between vitamin D and immune system. So basically all the cytokines, all the cells that are thought to be pro-inflammatory are going to be enhanced if you are deficient in vitamin D. And higher levels of vitamin D are going to suppress cytotoxic cells, T helper 1 and T helper 17, which are the T cells that are mostly associated with the development of this disease. So, long story short, basically populations that have a low incidence of vitamin D or are deficient in vitamin D, they have a higher risk of multiple sclerosis, and patients who have MS having low vitamin D is associated with worse outcomes. So we recommend all of our patients to take vitamin D to measure their levels, and we recommend levels that are in between 50 and 70 nanograms per deciliter, and most patients in Colorado are deficient and require anywhere from 5 to 10,000 units daily. And those patients who have MS, we recommend to check the vitamin D levels in their kids, and if their kids are deficient, to talk to the pediatrician to bring the levels up in order to prevent the disease from happening. So this is just to show you that every single outcome that we look in clinic, whether it's number of lesions, number of relapses, disability, has been associated with vitamin D levels, and being deficient early on predict worse outcomes in the future. So that's an easy to correct modifiable risk factor that we can work on an individual basis, but also hopefully at the large scale global basis. So what is not clear whether this data is also relevant for other ethnic populations. Darker skin people might have a different type of metabolism or impact on sunlight on the metabolism of vitamin D. But interestingly, darker skinned individuals tend to live in areas with higher exposure to sunlight and lower incidence of MS. So we still don't know whether this is just a story that applies only to white Caucasians or to other individuals as well. SALT and MS, this is something that has been recently recognized. People that has an increase in salt in their diet have also an increased risk of multiple sclerosis. And there was one study in rodents that looked at the animal model of MS, and they did two populations, one animals with higher salt in their diet and animals with lower salt in their diet. And similar to the story of vitamin D, animals with higher sodium content in their diet did worse and had higher likelihood of developing a MS model after induction with myelin products. In humans, it's a little bit difficult to actually measure this relationship, but this is one of those risk factors that we can easily endorse to modify in our patient population. If that doesn't work with MS, will work for other risk factors or other disorders. So we do recommend, at least I do recommend, patients with MS to try to lower their sodium intake. And the recommendations, the World Health Organization recommendation is do not exceed 2 grams per day. So it's always difficult to know exactly how much sodium you're taking. So an easy recipe for patients is do not add sodium to your foods if you're cooking, and try to watch the intake with processed foods. This is the first study in humans, SALT and MS, and these people were followed for 2 years. They look at sodium intake in their diet, self-reported, as well as they measure sodium in urine samples. And they look at short-term outcomes at 3 months, and they saw that people that had a high intake of sodium, again, they did worse. They had a 3.95 a higher chance of relapses, as well as new lesions on the brain MRI. So another easy to modify risk factor that has a clear relationship with worse outcomes. The third one, and that we are very familiar with other disorders, cigarette smoking is bad for MS patients. Not only increase the risk of MS, and that's one of the thoughts in terms of why MS is increasing the risk, particularly among women, as well as once you have MS, will make any possible outcome worse. So we are very aggressive in our recommendations in the clinic to tell our patients, take vitamin D, don't eat with salt, do not smoke, and of course exercise. And I'm not talking about exercise today because it's not clear the risk of exercise or low exercise in developing MS, but when somebody has MS, there is a clear relationship between lack of exercise and worse outcomes. So those are the 4 things that we usually talk with our patients. So that concludes the risk of MS category. We know that there are clear environmental factors that play a role in increasing the risk, and the same factors play a role once you have MS to have worse outcomes. Whether it's geography, diet, genes, viruses, migration, or all of the above, probably it's all of the above that play a role in increasing the risk of certain populations to multiple sclerosis. So in the next few minutes, I will talk to you about what is MS. What happened with these patients. So we know that there is a preclinical phase that is represented there in which the disease is already happening and nobody knows about it. Accidentally, patients may have an MRI because they had a car accident or they have headaches. And we look at the MRI and it has a typical lesions for multiple sclerosis, yet patients never had the symptoms. And that's what we call radiographically isolated syndrome, or RIS. Patients that never had symptoms of MS, but when you do MRIs, it looks exactly like a brain MRI for an MS patient. Here you see all those yellow arrows. They represent the likelihood and frequency of lesions on the brain MRI or cervical or spinal cord MRI. In the first 5 to 10 years of the disease, most patients with MS will have anywhere from 5 to 10 new lesions every 18 months. So basically you tell a patient, if we don't do anything, in 3 years you may have up to 20 new lesions. And that's hard to predict, but there are certain clinical and MRI predictors that will tell us what is the likelihood of that from happening. So it's very important to diagnose MS very early and also to intervene with medications very, very early. So after the first event, which is represented here, or relapse, patients without interventions will continue to accumulate relapses and events probably 1 every 18 months or 2 every 3 months. And after each event, as they grow older, they have lower likelihood of recovering. So in the first one, if you're young, you may have an optic neuritis, you may have a cerebellar lesion causing ataxia, and after 2-3 weeks, you may completely recover. But as you get older and your remyelination and repair gets more dysfunctional, the likelihood of recovery gets low. So and that's why in this cartoon you see that every time they have a relapse, they accumulate some disability. And when that reaches certain thresholds and you lose that ability to compensate with your brain reserve, Tim Ballmer is one of the world experts in brain reserve. When you use all that capacity, well, inevitably you go to this point of no return in which you constantly accumulate disability. You need a cane. From a cane, you go to the wheelchair, etc. So the key in success in treatment is treat early and treat aggressively. So time window for early treatment. So as soon as you make the diagnosis confidently, you should start treatment with these patients with therapies. We currently have 10 approved medications, and I will talk in one slide at the end of how those drugs look like. Most patients with MS have what we call relapsing remitting MS, and that's exactly the graphic that I show you. You have relapse, an event, usually lasts 3-4 weeks, and after that patients go back to baseline or accumulate some disability. Most of those patients will evolve in what we call secondary progressive MS, and that's exactly what I show you here in the first slide. After you reach certain disability continues to get worse, and you continue to accumulate lesions and lose brain or brain atrophy. And there is a proportion of patients that start without relapses early on, and we label those patients as primary progressive multiple sclerosis. There is absolutely no evidence that these disorders are different. Those are just simply different clinical labels. And the risk factors that I talked to you before apply for whether you are relapsing remitting or primary progressive MS patient. So I learned how to do animations, so I use them here. And this is what happened with the first relapse. And most patients will have either sensory deficits or motor deficits. Typical scenario, a patient wakes up, lose sensation in the hand, numbness. As the day progressed, the numbness continued to progress over the arm, the shoulder, and the rest of the body. The symptoms usually last 2 to 3 weeks and slowly will get better. So sensory symptom as onset usually has a better prognosis than motor deficits at onset. A patient that has the same symptoms, but instead of numbness is weakness. So each of these symptoms has a different story and may help us as predicting risk of disability over time. But regardless of the symptom, most patients with the first relapse will have a higher chances of developing the second relapse early on. So there are 3 phases of the disease in terms of the pathophysiology. The inflammatory phase is that pink triangle that as the younger you are, the more likely that this inflammatory phase be very, very aggressive. That's the immune system reacting to your brain cells, and that's the immune system that causes these lesions. Of course, you have some repair, and that's the yellow triangle. The brain will try to regenerate and repair and remyelinate. And all those factors are going to be primarily active early on in life. So the younger you are with MS, the more likely that brain will recover. And that's why we see that kids with multiple sclerosis, they tend to have a very aggressive presentation with lesions everywhere, what we call polysymptomatic presentations. However, when you do an MRI 6 months later, you might not see any of those lesions because the repair mechanisms are very, very active early on. As you grow older, you lose that chance to repair, and that's when you start to accumulate degeneration, loss of brain parenchyma, what we call black holes in the brain, which is actually literally loss of parenchyma in areas that you primarily and had lesions before. So those are 3 pictures of pathology. We usually look at the H&E stain, and you see the typical infiltrates of immune cells around the blood vessels. That's a perivenular inflammation. If you do a myelin stain, looks sulfase blue, you see that normal myelination should be blue, and in those plaques or areas of demyelination, you see a lack of stain or a white dot. And in an axon stain here, you see that a normal axon should be just a line, and you start to see now that there is interruption of the axon, and that will retract with the axonal bulbs to both sides, causing axonal interruption of the pathways of that given area. And if you do an MRI in that place, you will see a nice big black hole. So this is a point of no return, again, when inflammation starts to fade down and when degeneration continues to progress. And that usually happens anywhere from 15 to 20 years from the time of diagnosis if you don't intervene with medications. This is a nice cartoon that shows you what happened with these cells. We know that it's immune-mediated, and we know that the T cells and B cells play a role. So that's a blood vessel on the top. You have the immune cells. You have the blood-brain barrier that we all learn in med school. And somehow this barrier is going to become more permissive for cells to go through. And those cells will now enter the compartment of the brain. And if they have the tendency to react to self-antigens, autoreactive cells will start to recognize myelin or the axons and will mount an immune response. And that's the primary reason why we think that MS is immune-mediated. We'll still don't know whether the signal that activates the whole process starts outside the brain, that's the outside in theory, or something happens inside the brain that causes degeneration and subsequently recruits cells from the periphery to come to the brain and try to fix that. That's the inside-out theory. So we still don't know what triggers this whole process, but there is a clear association between immune cells getting to the brain and causing immune-mediated demyelination. So I spent quite a lot of time with this cartoon to try to make it move. So I'm going to torture you now with this to show you that there are many cells involved here. So this is outside the brain again. This is a blood-brain barrier. This is inside the brain, and that's a brain cell, a neuron. The green dots are the areas of myelination. Those cells are the cells that create myelin in the brain. Those are the oligodendrocytes. And then you have all these multiple cells. So basically, pretty much every cell in the immune system has a role in MS, not only T cells, but also B cells. And there is a cascade of events that occur once these cells reach the brain, that those cytokines are going to perpetrate a chronic inflammatory response in the brain. Astrocytes, microglia, and other cells also are involved. So again, going back to what causes MS, you need something to trigger the first event, but also you need to have an immune system that is more prompt to respond in a very dysfunctional way to whatever signal first activated the disease process. So this is how a brain will look with an MRI. Those are axial views of the brain, meaning the cuts are done in this way. And that's a sagittal view of the brain. And you can see all those white dots. Those are areas or scars where there was demyelination before. As you can see in the sagittal view of the brain, the lesions tend to be ovoid-shaped, and the long axis of the lesion tends to be perpendicular to the long axis of the lateral ventricle. If you look at those, they look like fingers getting from the corpus callosum to the brain. That was described by Dawson, and they're now known as the Dawson's fingers. They're not pathognomonic for the disease, but very typical for multiple sclerosis, and this is all it reflects is that perivenular demyelination that I showed to you before. We know that the veins in that area will run perpendicular to the corpus callosum. So all you see there is a classic perivenular demyelination in multiple sclerosis. It's always in the board, so for you guys that are taking your board soon, you may want to remember the Dawson's fingers. If you see that, most likely the answer is MS, because it's typically seen in MS. If you have the luck to do an MRI in the process of an active lesion, a brand new lesion, you may see enhancement. And those arrows show you that after you give the contrast technically should not get to the brain. If there is an abnormal blood-brain barrier, the contrast will get there and you see an active enhancing lesion. Enhancement lasts for up to 4 weeks. So if you do an MRI, usually tell patients, well, you have an active lesion. All I can tell you is that the lesion occurred within 4 weeks from the time of the MRI. So unlike what we used to think, MS is not just a white matter disease. MS is a disease of the brain and spinal cord. And with higher field MRIs, this is an 8 Tesla MRI, you can see that there are lesions in the cortex as well. So this outer layer of the brain, the cortical ribbon, you see nice lesions that are affecting where the neurons live. So the fact that MS is not only a white matter disease open up A lot of questions in terms of, again, what causes MS? If it is not just the white matter, that means that might be something in the neurons or the neuronal compartment that may trigger the disease from getting worse. And one of the most interesting articles about that is this article that showed that MS patients tend to have clusters of B cells that are hanging out there next to the cortex in the intermeningeal spaces. And those ectopic B cell follicles are directly related to these cortical lesions. So we don't know whether the cells caused the lesion or the lesion it started first and recruited those cells, but there is a classic association between these B cell ectopic follicles and the cortical lesions in certain MS patients, particularly in secondary progressive MS patients. So in the next few minutes, I'll talk to you about therapies that we have available, and then we can open up for questions. So basically, again, going back to the blood-brain barrier, this is inside the brain, and that's outside the brain. We talked before that most of what is happening happens inside the brain, and unfortunately, we don't have good therapies that has a proven a mechanism of action inside the brain. So all we are doing with our therapies is modulating or suppressing the immune system outside the brain. Everything that you see in red are medications that has been approved for the use of MS. And I didn't include the old ones, which are injectables that should be in that category, which are interferons, beta interferons, and glutaminyl acetate. But we have BG12, fingolimod, natalizumab, and teriflunomide. All of those drugs have different mechanisms of actions. They offer anywhere from an efficacy from 30% risk reduction of new lesions and relapses to 80 to 90%. So you can tell patients with some of these drugs, like particularly in natalizumab and rituximab, that if they are taking that medication, they may have an 80 to 90% less chances of new lesions, new relapses, or progression. So this is a significant improvement in our treatment for MS, and those numbers are particularly true the earlier you start the treatment in their life. So what is the goal for the treatment in MS? Well, we want to get rid of inflammation, we want to stimulate regeneration, and we want to impact on degeneration. So we don't have therapies yet that enhance remyelination, though if you're getting rid of inflammation early on, you might be indirectly impacting in the ability of the brain to repair itself. So there are a few therapies in clinical trials that are very interesting from a mechanism of action standpoint that might help us to help patients regenerate their brain and remyelinate, but nothing has been approved yet. So the last slide, take-home messages. There is an increased prevalence of MS as well as an increased incidence of MS, particularly in women. There are factors in the environment that will play a role in increasing that risk. Basically, the population genetics, the interplay between genes and environment, and also socioeconomic structure of the places where patients are coming from might impact the risk of MS. We know that there are modifiable risk factors. We talked about vitamin D, salt, smoking, that affect not only the risk of MS but also outcomes. And something I threw there at the end, is this hygiene hypothesis real? Do we truly see a relationship between development of certain infections and the modulation of the immune system early on in life that might change the risk of autoimmune disorders? So thank you for your attention. I just want to briefly announce that we got approval from GME for our first NeuroID combined neuroimmunology fellowship. Dave Beckham is the fellowship director for that, but that's a joint effort from internal medicine and neurology. And this fellowship, we just got the first a candidate. We interviewed last week, and hopefully we'll get a first fellow starting July 1st. This person is going to do half-time neuroID, half-time neuroimmunology. With a lot of overlap, we are going to continue our efforts to develop an HIV clinic. And we will love to also offer some global health opportunities. So we're going to be working with Molly and her team to try to make that happen. And of course, we are working to also offer international neurology opportunities to our residents and fellows in neurology to try to help us, again, collaborate with other centers and understand more of our disorders. So thank you for your attention and for not falling asleep. And then I'm open for questions.
the most effective drugs don't really cross the blood-brain barrier that affect cell migration. How is it that they improve disease as opposed to just preventing worsening of the disease? That would more logically occur in the periphery, preventing things, but it didn't seem to work on lesions that are already in the CNS. So what's the mechanism? How does that work?
So exactly. So every drug has a story for. Let's start with the most effective one that is approved, which is Tysabri or natalizumab. So all this drug is doing is preventing immune cells from crossing the blood-brain barrier. Of course, if something already started in the brain, which something did because patients are already diagnosed with MS, you may not be impacting in immune activation inside the brain. So all you're doing is, if there is further recruitment of immune cells getting to the brain, you're preventing that from happening. Clinically, we see that these patients have an absolute stop in the disease process. Most patients on Tysabri will not get more lesions over time. Relapse rate significantly decrease. But if you start Tysabri in a patient after 20 years from diagnosis, the progression of the disease will continue to occur regardless of the treatment. So if a patient had MS for 20 years and probably has those ectopic B cells already happening in their brain, and you put them on highly effective therapies, they will continue to progress regardless of the medication. So the key is early treatment. Once the disease started the process and you have microglia activation in the brain, you have B cell ectopic follicles in the brain, no matter what you do in the periphery, the disease will continue the natural course. Did that answer your question?
Well, sort of. I mean, but there are patients who get better. They have neurologic improvement. So that means the axonal lesions that are being affected by what if the drug isn't getting to that part of the cell? So that's my question.
Okay, so now I got it. So I always explain to patients in this very graphic story. So you have a city, and the city is your brain. And you have a bunch of people that is creating mess in the city, is getting trash to the city, to the streets. And you have a bunch of people that is cleaning up that mess. What you're doing with Tysabri is you get rid of the people that creates the mess, allowing the people that clean up the city to just do their job. The brain has normal repair mechanisms early on in life. So if you're getting rid of inflammation, you're allowing the brain to repair by itself by natural mechanisms. So indeed, you don't enhance repair, but indirectly you're allowing the brain to repair itself. The younger you are, the higher the chances of repairing from happening.
And that includes improved sheathing and new axons?
Exactly. So when you look at, for example, OCT, which is the best way to look at the density of the axon, so that's just a picture of the optic nerve. You see that patients on Tysabri, not only they don't have further damage to the optic nerve, but actually they have improvement of the density of the optic nerve. It's not because the drug is doing that, it's because now you're allowing for normal repair mechanisms to take place.
Yes, I have a question about ethnicity and treatment. We use the same drugs and we use the same dose, or for different presentation, if it's optic-particular versus...
Yeah, that's a great question. So doses, yes, doses are the same, but there is an overlap between the opticospinal MS that I talked before with the Asian population and the South American native population and neuromyelitis optica, which is a different neurological disorder. Those patients tend to respond better to anti-B cell therapies because the thought is that these B cells, by an antibody-mediated mechanism, will be the ones causing the disease. So why the optic nerve and why the spinal cord? So there is an antibody that reacts to a water channel called the aquaporin 4 channel. And those channels tend to be highly represented in the optic nerve and the spinal cord. So the thought is that those patients have more of an antibody-mediated disorder than the typical MS patient. And those patients tend to respond better. So again, Latinos, particularly Native American, South American people, and Asian people respond better to B-cell therapies than these T-cell mediated therapies mechanisms. All right.
Very much.
Thank you.
Thank you.